Pino, Pompomochum, my anything, I'm a smart nip him. Me, Mademo, Magabu, Mawaga, Dolala Halaga, Maba Ace, Namanago, a Kukuga, and your Chicago, Yenya Dam Debo, Nama Jiba Yakodo Yala, Lamadeka, Adonazanu Yoyanaba, Condom La, Nasila Doyawuna Nako, in Chifafa, Nanapa Dukona no Jim, Kabakaba, Cho, Kabakaba, Kabakaba, Masada Kumuke, Zamumuku, Gargadi, the one the Mugunchiwa HIV, Kekashewa, the Baba, the Ma, Wallahi Kunjiko, one and Chiwa HIV, Wallahi, Bashako, one and Gargadi, Friction, Yerebuto, Kokaki, Kokaso, Wallahi, Mumpada.
It is real, my brethren.
You can maintain one lover.
Rastafari come to warm you.
It's not on, it's not in.
But I'm killer, this is nonsense.
You can wait until marriage.
We got no remedy.
It's all about the AIDS. You don't want me to now. Don't forget about your condom. I know from the rubber socks. You know who you are. I'm not telling you.
My lad, yes, if we are better to recognize. Those years, you never come live in a paradise. 1 hour days make you feel free like ice. Natural robbers make you die like flowers. Mothers and women, them a die like houseflies. Don't use it, please take and recognize. And just think twice again. My lad.
Zinopar, show who can fall. Say you can't catch ya, hold up on his mother. It's your baby, Sakapa, yeah, Narewabo. Enti down yanko, so down yanko, Munyan the bonny down, Mayamini winning, what kind you know. Now Sunday better. You can maintain one lover.
Rastafari know.
It's not on, it's not in.
It is a killer, killer, killer.
Until marriage.
Can't stop it. Oh mama, hear my cry.
And you know, Yana, I'm the permanent here being come here. And then we could be saying, I see I saw a question. Given a year now, when you're my answer. Yari, a kiss here now, and the international crew. You didn't call on the room. When you get www.com with me to the summer home. Some of the shop. Now we ask my attack, rat me up on Chamakama.
Charlie, there is nothing wrong with having good sex. But use a condom, Charlie, there are many to select. Secure, Panthers, and even Durex. Use a condom, Charlie, and protect your health.
AIDS be real, but you sabi the deal. The last girl where you drop will be your last meal.
We tell them it's a dangerous disease. I'm on advising. It's on this office. A warning, put on your condom. Protect this kingdom. Protection before the action. Abstention prevents abortion. Original Rascorby warning.
Now really know when I call him. It's not Malani, no more Jabele. Koya Dale, Cranny, if it's Boshi, oh, Yake, Hagana, Mamufe.
Wami Anganio, Eti, Urukuma Vishi, Urukum Inzifu, Wami Anganio, Shawa Mampino, Yapa.
I was carry a dog who missing you. The married couples owing you. I said, we're amazing, my foot on you.
Did you see that?
Yes. That was the song.
Yeah.
That was the song I was referring to.
But
see how nice, like you can even, the lyrics are easy to follow. I love it.
It was good.
It was
and
a
even
good
at the
campaign.
latter part, I saw every day 200 people contract the HIV virus. And well, let's see how it is now and what the statistics are now, and if the education has really gone down and if people are adhering to what we would term as the protocols, whether they are really going about it. But in studio is Caroline Adonadaga, who is the head of prevention, counseling and nutrition at the National AIDS and STI Control Program, and she's joining us in studio. Later, you definitely have a doctor from the Ghana AIDS Commission who also join for us to have further conversation of what is happening in the country. Good morning, madam. How are you doing?
Good morning. I'm doing well.
Good, good, good. How is it going with the... First, let's start with education. Because like Eno said, it's been long we saw this video play on TV, or we heard of the song air on radio to sort of push down the education. How is education on HIV going?
Yeah, as a program, we are doing our best. And just as she indicated earlier, I got excited when I heard this song because it was all over the airwaves. Everybody was hearing and were educating, were entertaining. All of a sudden, everything is off. And I think you need to be doing this for us. Yes, because we don't have the money to ask for the space for us to do this, but as part of our corporate social responsibility, if all the stations can do this from time to time, I think it will help us. But we are educating, and that is why we are here this morning. You have called us here. We are also in most of other platforms that we talk about. And in moving forward, we want to also leverage on social media.
Yeah, beautiful.
Yeah, it's a two-edged sword, but I mean, it's a very powerful tool if you really want to reach our young persons, the youth, in HIV prevention activities. Okay.
But how is it going now with the figures, with the HIV statistics that we have in the country now? Are the numbers reducing or the numbers are increasing? And if you can give us the national outlook, what are the numbers now? Okay.
So for the National AIDS Control Program, just as I indicated earlier, we are under the Ghana Health Service. And this was set up in 1986, after we diagnosed our first HIV cases in 1987, after we diagnosed our first HIV cases in 1986. And as at the end of 2024, about 334,721 persons were estimated to be living with HIV in Ghana. And then we also have the new infections that occurred under the same year. So new infections were about 15,290. And then AIDS-related deaths were 12,614. So that's on that outlook. And then for our prevalence, if you take 100 Ghanaians, general population, and test them for HIV, you are looking at about 1 or 2 persons testing positive for HIV. That's among the general population, because our prevalence now is 1.49%. But then, that is general population. We have subpopulations in terms of groups of people. If you take people who have been diagnosed with other STIs like gonorrhea, syphilis, chlamydia, and all that, 100 of them and test them for HIV, you are going to get about 9 of them testing positive for HIV.
Wow.
You are getting about 9 of them testing positive for HIV. Then you take people who have been diagnosed with TB disease, active TB. We all have TB, bacilli as we sit here, but we don't have the disease. For those with the disease, when you take 100 of them and test them for HIV, you are looking at about 12 of them testing positive. Because the prevalence among this group of people is 12%.
Wow, I like the general.
When you look at, you take female sex workers, 100 of them test them for HIV, you are getting about 4 to 5 of them testing positive for HIV. You take men who have sex with men, 100 of them, you are getting about 26 of them testing positive for HIV.
26?
You take transgender women, you are getting about 48 out of 100 testing positive. You take pregnant women, 100, you are looking about 1 or 2 testing positive. So all these statistics I'm giving, it just tells us that we are a country that has a generalized epidemic. Even though other subpopulations are contributing significantly, it is everywhere. Wherever you pick, children, adolescents, adults, there is HIV. And that is why we need
a point that you made about the men with men and also the trans I noticed the numbers have increased in that area. I'll come to that. But joining us is Dr. Fred Nanapoku, who is Director of Technical Services at the Ghana AIDS Commission. He just joined us. Let's speak Dr. Poku's thoughts on the statistics now on the AIDS infection that we are having in the country now. Doc, good morning and thanks for joining us this morning. First of all, what is the outlook for the Ghana AIDS Commission?
Well, in 2026, we want to see new infections coming down drastically. Unfortunately, it's quite high. Last year, we had more than 12,200.
So you have done your ratings, or you have been able to collect?
2024.
Okay.
For 2024, yes. That was more than 15,290 new infections occurred in Ghana, which is not interesting and it's not good enough. So we want to ensure that new infections comes down drastically. We're currently looking at developing our national strategic plan, which will define some of the targets that we will have for the country. So stakeholders will meet. We have done review of the last strategy, and then we have seen the lapses, we've seen the success stories, we've seen where we can strengthen the response. And we are hoping that in this year, moving forward, we will have more reduction in our new infections.
Wow, Doc, thank you for that quick intro. But let's come to Caroline again. I was asking that when you made mention of the statistics for pregnant women, for sex workers, for men with men, trans and all that, why do we have the numbers trans and men with men increasing? From what you know?
So we are talking about prevalence. Prevalence in the sense those who have the existing cases that we have here. And it's increasing because of the mode of the act, okay? Because it has to do with an area that it easily bruised, okay? That is it. But then that's why I was quick to say that even though prevalence among these groups is high, it is everywhere. And the question I always ask people is, we say female sex workers, who patronizes them? It's our brothers, it's our husbands and all that. And this figure or statistics I'm giving about the prevalence among men who have sex with men, that same study came out to tell us that 50% of these people are bisexual, meaning that they are the men in our homes, our husbands, our brothers and all that. And that is why usually, even though we give out the figures for education purposes, for intervention purposes, we do not want to single out any, because people within our homes belong to these groups. Okay, and so it is everywhere, even though others contribute significantly to
that
it.
there's a higher proportion of new infections among females. What is accounting for this?
Yeah, for the females, you know, where we find ourselves, I'll start with even our biological makeup. You look at our genital area. You see the surface area is so wide, okay? And so as the sexual intercourse is going on, the attraction in and out, there's a likelihood of bruising and all that, you get it. And the man ejaculates. If she's positive, if the man is positive and ejaculates, it's there. Remember the penis, they say we should say, excuse me. Yeah, so the penis, yeah,
it is what it is.
Part of the penis is like the skin, you know, and it's a barrier. And so and aside that, you can have one man infecting about 5 or more women.
Wow.
Yeah, because one man can have more than 5, 2, 3, 4 girlfriends. That's what I'm saying. But the vice versa, you hardly get one woman, even though it's not impossible doing that. And so if one man is positive, the man can infect as many people as possible. And then another thing sometimes is just the fact that women are those who visit the facility for diverse or different reasons. And so we are able to get them and we screen them and then we identify the cases.
That is to say that there are some numbers or there are some people who have not even visited a health facility to even get tested.
That is the men, yes. Even though...
It's not only the men.
Dr. Mogo wants to disagree with you on that.
So yes, with the statistics, if you look at our estimated population, PLHIV, I'm talking of persons living with HIV population, about 68.5 of them are females, just as you rightly said. If you look at the new infections that occurred in 2024, about 67% were females. Wow. You look at the AIDS-related deaths, about 56% were females. Wow. But the other aspect of it that is even more alarming has to do with the fact that we have children 0 to 14 years who 10% of them were among these deaths that occurred.
And how did they get it from their
parents? Through mother to child.
Mm-hmm.
And then the new infections that occurred among the, 0 to 14 accounted for about 8% of those new infections.
Wow. But let's look at regional statistics.
Yeah.
So we have 16 regions. From your check from the Ghana AIDS Commission, which of the regions will you say that we have a lot of numbers, or we are recording a lot of people who have contracted the HIV/AIDS?
It's Greater Accra region. The persons living with HIV, there are more than 77,000 in Greater Accra, out of the 334,000, over 334,000 people. So Greater Accra has a huge number of persons living with HIV. We come to Ashanti, we have a lot of people there. We come to Eastern region, we come to Bono, etc., etc. When we go to the northern part of the country, the infections are low, or lower than what we have in the southern and the middle belts of the country. Northeast, northern have the lowest, Savannah, they have the lowest numbers and the lowest prevalences in the region. To add to what my sister was talking about the females, I like that because women are the brunt of the infection. And one of the data that we have is what we call the transmission index, the ability or the propensity for transmission to occur from a man to a woman, and from a woman to a man, or a female to the other partner. In fact, our transmission index, which measures how many infections can be produced by a single man or 100 men who gets infection, is 3 times more than that of women. It means that 100 men can transmit 3 times infections more.
Wow.
Wow.
To their female counterparts than men. Wow. The index from male to female is 9.7%. And from female to male is less than 3%, about 2.95. And the country's index is about 5.3. So young ladies, young men, you have to be more careful and more aggressive in negotiating when you're having sex.
Shouldn't even be a negotiation. I think it should be
we negotiate to have safe sex, to get condoms, to use condoms, because it's very difficult in recent times. And
what has accounted to the difficult thing about the usage of condom? Let me deal with Caroline. I'm sure that you are with the prevention, and you have been going out. You've been hearing people. What is it that they've not been able to do to use the condom one? And what are you doing at your outfit to protect women? Because you are saying that the risk associated, or they stand a bigger chance of being infected.
Yeah.
Yes.
Yeah. So I think it has started from that of the condoms. The condoms, yes, I mean, they are the only way of, if you use that one, it gives that dual protection. Protects against pregnancy, and also protects against sexually transmitted infections. But the issue here has to do with the stigma surrounding everything about sex in this part of the world that we live in.
Oh, okay.
We all have sex.
Really?
You
Oh,
see
you're
even
asking really?
you see even in people who have delivered their children, nobody wants to talk about sex.
Yeah.
It's like an unwritten taboo somewhere. And that is one of the problems. And so when people want to use the condoms and they have to go to a pharmacy shop to purchase these condoms, sometimes I say that it's not even the people around, it's some kind of self-stigma.
Yeah.
The fact that when you are going, you already are thinking that people will see you buying condoms. And so even going for the condoms is a challenge. And when people see you using condoms or going to purchase, it's as if you are promiscuous and all that. And we want to change that narrative. All our people, our viewers, our listeners, understand that using condoms is a form of responsibility. You are trying to be responsible to prevent getting new infections or sexually transmitted infections and also transmitting to others.
But you used to give condoms out in tertiary institutions or in senior high schools. It's called Be Safe. Do you still do it?
No. In fact, for senior high schools, no condoms.
Okay, so tertiary.
Tertiary.
Okay.
Because the GS protocols, you don't even, when you go to the SHS to give education, you are not supposed to even talk about condoms.
Oh, okay.
And that is an area that's a gray area that we need to look at. Because it's time for us
having sex.
Yes,
Let's be honest.
To stop playing ostrich.
Don't look at me.
Yeah. and so these are some of the things that come back to bite us. They are already having sex, but we are pretending they don't.
Yeah.
And people, they keep saying, if you educate them, you are spoiling them. But I think that is empowerment.
Yes.
You are empowering them to be responsible in their lifestyle because they are a future generation. And just as I mentioned earlier, prevalence amongst them is increasing. They are future workforce. Should we just pretend that they don't have and wait for them to get infected? And that is another gray area with our condoms and all that. Another area that we are looking at, and Dr. Poku is here, GAC is planning to get these vending machines at vantage points where you go, there will not be any stigma if they are in washrooms of the malls, public spaces where somebody can just go and take your condoms and go away. That's fine. And I watched a program on UTV recently, and they were interviewing these young Okada guys, and they were talking about, no, I don't use condoms. It's not, it doesn't feel the same and all that. You don't get the taste. The women don't like it. And so we have a lot of work to do for people to understand that, look, it's better to enjoy halfway and live longer, healthy, than to have it, the full package, and then die early.
Doc, you have something to add to
just to add to that. So we're looking at condom access programs. That is what we want to do. In fact, when you go to other countries, Kenya, South Africa, they have these condom access programs, even for secondary school students.
Wow.
And research has shown that really it is not the availability or access of condoms that causes or stirs the youth into, in quote, promiscuity or sexual activity. It is not that. It is already there. So providing the condoms is rather protective rather than kind of encouraging them to do social vices. And they have these programs they call condom access programs. And if you are sexually active, there's a way you can just engage with your supervisor or whatever it is, and then you have access to these condoms. We're thinking of increasing the accessibility of condoms through the non-traditional methods. Currently, we know that it's just the pharmacies and, as you were saying, etc., that you can access the condoms. We want to look at how to make them available everywhere, anywhere, when you want to use it.
Wow.
And then, you know, Ghanaians, we already have this mentality that anything that is free is inferior. It's not good.
Yeah.
So there will be some small token that you insert into this vending machine, and then you can access your condom. And we want to put them at vantage points. We have to develop the concept already, and we are looking for funding. That's one of our main main functions is resource mobilization. So looking at how to really get some private sectors and other institutions involved so we can be able to bring this to reality.
Caroline, do you still preach be faithful or abstinence? Or what is the main key thing you tell the youth and also people who are having unprotected sex?
Yes, we do still preach those traditional methods of or ways of HIV prevention. They are still key. So we preach them, but we have also now gone a little further. Times have changed and we need to move with time. And so aside our being faithful, I mean, first abstinence for the younger ones, and then for those who are already in relationships, they need to have that mutual faithfulness. But of course, you need to know your partner status, and then you have that, and then the use of condoms correctly and consistently. Aside that, we have moved now to using what we call this pre-exposure prophylaxis.
What's that?
Pre-exposure prophylaxis. They are medicines, the HIV medicines that people will take. Somebody who is at high risk or has a substantial risk of getting HIV. They are available for that person to access and be taken, so as to prevent the person from getting HIV. And they are taken daily. And then there are others that are other people can take it event-driven. The person knows that, okay, I'm going to meet a partner, maybe who is HIV positive, who I don't know the person's status, but I'm going to engage in a raw sex. So the person goes.
So the person plans ahead.
Yes, it's a planned thing. It's pre-exposure. Pre-exposure. So you go for it.
I think a message has been sent on the why is PrEP. It's called PrEP.
PrEP.
Right?
Yes, that's PrEP.
Why is PrEP widely accessible and publicly promoted in countries like South Africa, while Ghana, many people are still unaware that such HIV prevention drug even exists?
Yeah, so that is why we are here and we are talking about it. In fact, some people know, but then it's the education, just as I say, if you give us these platforms and we talk about it, people get to know. So we have that in the system, but we have the oral PrEP only, but we have other new technologies when it comes to PrEP. That's the pre-exposure prophylaxis. We have a vaginal ring, that's the Pivrim vaginal ring, where women can insert. It is loaded with the ARVs, that's the antiretrovirals or the antiretroviral medicines. And then it releases slowly for a month. They go, and they take it off. And then there's another one, Kabla. That's also a long-acting injectable. That one, the person goes for the injection. It lasts for 2 months. And then after that, the person goes again. And then we have another one, the Len. That one, effectiveness, very clear, over 99% effective against prevention. And that one is taken twice yearly. So the person goes for that injection, it covers the person for 6 months, the person goes again. But unfortunately, we do not have these new technologies of preventing HIV in this part of our country. What we have is just the oral, the pills. Pills, people get tired, adherence becomes an issue.
How often do you need to take these
pills? No, we have the daily one, so long as the exposure exists, so long as the risk exists. I mean, if you know that or continue to engage in risk, it means you have to keep taking it. And some people, because of stigma, because it's the same medicines we use to treat HIV, just that the treatment, there are 3 medicines, mostly put in as 1 tablet. But with prophylaxis, there are 2. So some people even don't want to take it because if you take it home and somebody sees and knows that is one of the living thing that you're already positive.
So there's also a stigma attached to that one.
Stigma attached to it and all that. And so the way to go is these new technologies that we need to. And we have written some proposals. And just as Nana Poku said, I mean, it has to do with funding. And if we get all these things.
Is the current national HIV strategy adequately funded? Well, since we're talking about funding.
Adequately funded?
Yes.
Are you asking me that question?
Yes, I'm asking you that question.
No, we have huge financial gaps. In fact, we need a lot of money. I think we are looking at about $150 million and things like that. We are nowhere near that. we sometimes have about 55, 45, and all things like that. So there's a lot of gaps in our funding aspect. That is also responsible for some of the gaps we are seeing in our strategies, implementation, and in effectively providing prevention methods. In fact, we were just talking about this PrEP issue. One of the key factors that it is not open to the public so much currently is that of knowledge aspect of it, because people might misuse and then we get resistance to HIV. The second aspect is the funding issue, because it is currently free.
Well, the PrEP is free?
Yes.
And how do you assess it?
How do you assess it?
How do you get it?
You have to go to the facilities. We have a lot of facilities that can give all the ART centers across the country. We have more than 750 sites that provide ARVs for treatment. When you go there, as an individual, you'll be assessed, your risk profile. And after that, you consider you eligible or not. And then you do a few tests. And first of all, you have to be sure you are not already positive.
So it's not like it's in the pharmacies?
No, not really. Not really, it's not. And then after that, you are given. So funding is an issue, knowledge and the risks of whatever is also an issue. So we have to increase knowledge first about it, and then also look for the funds to support that program. We are also looking, as you were saying, at getting the more recent innovations, the injectables, into the system. And as you said, you get once, twice in a year. In fact, they are even looking at getting once a year injectables. But currently we have the ones, the lenacapavir, which you inject twice in a year, and then we are protected. It's like taking malaria prophylaxis. Pregnant women will take some medicines to prevent them from getting malaria, or somebody coming from the UK or Europe thinks it's coming to Ghana where malaria is endemic. So it's a prey before you are exposed to the mosquitoes and all that agents that might cause malaria. You take that medicine. It's a similar concept that is applied to HIV.
I know most of your funding probably would have come from outside, but in the face of donor shifts now, that must be a tough call for fighting AIDS in Ghana in general.
Yes, we lost quite some substantial money from USA. About $14 million was what was expected last year, but we couldn't realize all of that. And then we also lost some amount from other sources. So the funding challenges is huge with us. But luckily, prior to all this, we had already started or initiated some sustainability plans. So we were able to develop a very comprehensive sustainability plan, which was launched last year, just the latter parts of last year, and then we are about implementing. And that looks at more of non-traditional sources of funding, internally generating of funds that will support the response. So we are hopeful that with the implementation of this plan and other measures that we are trying to put in place, getting the private sector, corporate entities involved, we will get adequate funding to support our program.
Caroline, let's talk about the stigma. How are you dealing with the stigma now? And if you tend to see someone who, in a way, has contracted HIV/AIDS, how do you deal with the person? Because I think it's part of the reason why people would not want to come out to get tested and see the figures we have by way of people who have contracted this infection or this disease.
So you are if I understand you, you want to know
how your outfit is dealing with stigma.
With stigma, yeah. So for stigma, we have collaborated with other organizations. In fact, previous grants, we had some of our SRs like CHAG, okay, working, and we trained health facilities in the country, I mean, to reduce stigma. They become stigma-free facilities, because sometimes the stigma even starts from the health facility. Okay. Because if I go and test and I test positive, how will people outside get to know? So the first thing is to address that stigma from within the facility itself, so that when clients come and test positive, they know how to keep that in confidence, because it's somebody's health information. Are you getting it? And so we have done that over the years. There's still much to be done. In fact, another thing that we are doing with another partner now is to incorporate these models that we used to train the in-service persons, I mean those who are already out of school and they are practicing, into the pre-service training curriculum. So our nurses training colleges, our midwifery training colleges, as part of the content of the course, these models are taught, preparing them to have that open mind, stigma-free minds, to see every client as the same and unique, so that when they get out, that's already is in their minds, and then it goes on as it is. Another thing that we are doing is we are using some of this same PS. So for instance, you go to the ANC, you know, we have women, because of our EMTCT, that's eliminating of mother-to-child transmission. Pregnant women are tested. So we have some models, we call them KDES. These are women who tested positive when they were pregnant, went through the interventions, gave birth, and have HIV negative babies. They are looking healthy. So they have availed themselves as models, let's say, support systems for the newly diagnosed positive pregnant women. They use themselves as examples, and then they are, in fact, that is funded by the Global Fund, the current grant funds that they are giving some stipends, and they do that. And that at least addresses the stigma somehow. There's a phase to it. And so when one tests positive newly, I mean, that's a blow and all that, and so these people are there to support. You go to the ART, those who are not pregnant, we have the models of hope with them, who are already also HIV positive. They are on treatment, they are doing well, they are virally suppressed, okay, looking healthy, and so they use themselves to support, to address all this. When you look at our young adolescent and young persons, 15 to 24 years, we have the community adolescent treatment supporters. We call them CATs. They also support their age group, because it's better to, because if you ask an adult, the younger ones will not feel okay, so you get their peers to support and all this. And of course, as part of the stigma, our treatment models, we are using a model now we call differentiated service delivery. What it does is, yes, we're taking care of people, but we want to tailor our services to the needs of each client. Yeah, you can have 10 people with HIV, but their needs are different. Okay. And then you know that when people get on treatment, there are some people that after 1 year, 6 months, 1 year, they are virally suppressed. They are not sick, nothing happens, they are just HIV positive. And you have others.
Oh, then they move about normal.
Of course, people move about. You won't know that this person is positive. If you tell the person will be positive, no sickness, because the medicines have suppressed the virus, the multiplication of the virus to an extent where even if the person goes for them to take the sample to look for the viral copies, the HIV in the blood, it comes out that target not detected. The machines are not able to detect. It means that in the bloodstream, there are so few that they can't. And when the person gets to that point, the person can no longer transmit to other persons. Okay. And so what we are trying to do is this stigma, once the person gets to that point, it helps this person not to be sick. And so this model is like that those people will now give them 6 months supply of medicines. Instead of the person coming to the facility every month, and maybe people will see the person and all that, the person comes, we give 6 months. So the person visits the facility twice in a year.
And this supply, is it free or?
It's all free. In fact, HIV care in Ghana is free. Testing is free, treatment is free, viral load monitoring is free. Okay, and this is the cascade that we are doing. You know, we have an HIV care cascade. We are looking at testing, we are looking at treatment, we're looking at viral load monitoring. I'm sure you have heard about our 95, 95, 95 targets. And it's based on our estimated HIV population of 334,721. So we want that at least 95% of these people are tested. 95 for those who are tested and know that they are positive, put on treatment and achieve viral suppression. So these things, we are doing them to try to ensure that at least our stigma in the country goes way down. And we are also engaging community-based organizations in these services that we are providing. Okay. And as we are also here talking, please, somebody who is positive, that person is not a threat to anyone. Once the person is on treatment and achieves viral suppression, that person, in fact, technically cannot transmit the infection to anyone, even if the person doesn't use condoms.
I think you're changing the narrative, because those times when you say someone who has HIV, you can't even eat to the person, you can't sit by the person, the stigma and all that.
That was wrong information.
Yeah. That is the wrong.
But is HIV AIDS deadly like it was preached years back? Is it deadly?
HIV is a viral infection. Right? You can have a viral infection, you can have a cold, which is due to influenza virus. It's just that the viruses attack a different component of your body.
But Doc, is it deadly now, or it's...
It's not deadly.
Thank you.
You see, at the same time, it's deadly.
Doc, what are you telling us?
Yes.
Is it deadly or it's not? Because see, the reason I'm asking that,
I'm coming. Let me explain.
Minds, they are like, when you get it, then you are going down.
No, that's what I'm coming to explain. HIV is not deadly, but it is also deadly.
Okay.
There's no disease that cannot kill.
Okay.
Every disease that can kill you is deadly.
Okay.
Malaria per se is not deadly. But malaria kills a lot of children in this country than other conditions. So it is deadly. I'm just trying to bring our mind to certain components of HIV. First of all, about preventing it, that's why I'm saying it's deadly. And secondly, when you get it, going for your right medications and staying on treatment to get to the viral stages so that you don't develop AIDS, which is deadly. Right. Because when you get to the AIDS stage, which will have 4 stages, you can pop at any time, because any diseases can easily, you succumb to any kind of diseases and you can pop. So that is the deadly aspect of it. But as a condition, when that virus enters you and you test and you know that you have the virus, there are medications, there are protocols that you can have and you don't have any problem. But the previous concept, right, that we did not really understand the pathogenesis, the mode of acquisition, right, had made the stigma of HIV so ingrained. And that is what we are trying to change, right? Because, as you rightly said, you see that person who is cachectic, very lean, they tell you that don't even touch that person. Because we didn't understand how the person got the disease. Now we know and understand that touching it, you cannot, or touching or hugging or kissing somebody, you cannot get it. Because of the understanding of the mode of transmission, pathogenesis. And still, in our environment, because of this ignorance, people hold on to it so much. Hitherto, we thought that it was sex workers or, in quote, only promiscuous people.
Yeah.
So if immediately you are labeled or you test and you find out that you're positive, you are categorized. Stigma is attached to your name. Wherever you go, they just point fingers at you and all that.
Does it even affected people having businesses and all that?
Yes.
Someone is running an eatery and the person,
Right.
the status of that person is known.
Because
People
of the
don't go there.
ignorance we had. Today, as we speak, a 0 years person, somebody who is in the mother's womb, who has not even seen life, nor had sex or anything,
You can contract.
is contracting HIV. In fact, last year, 2024, more than 1,243 children were brought into Ghana from their mother's womb with HIV.
That's 2024 statistics.
I'm telling you, more than 1,200. Now, these people are in Ghana. Every year, if we churn out these people into Ghana, how then do you point at that young lady who is now 18 or 16, wearing a miniskirt somewhere, as because of her promiscuity, that made her get virus? How then do you stigmatize the person? How then do you prevent her from going to school? In fact, the demographic survey says that adults were saying that they won't allow their kids to school with people or other persons whose kids have the virus in their blood. As if by just sitting down and learning, teacher teaching you or breathing around, you can contract the disease. No, it's ignorance. There are some diseases, when I sweat and I touch you, you can get it.
Yeah.
So that one, that is why we have some contagious diseases that we we isolate cases and all that. COVID.
Yeah.
If I sneeze on you, you get it. Right? So that narrative, that's what I'm saying, that narrative that we had about HIV, that has to change. And that is where the education and understanding comes in. So today, as we're speaking, there's no reason behind stigmatizing people with HIV. If you have a problem with somebody's lifestyle, you can go quietly talk to or advise in your own way. But you can't stigmatize that person because he has the virus. Thank you.
But we are not leaving you out there. You can join us with your thoughts, submissions, and
There's
comment
some messages
on
though.
the HIV/AIDS conversation. In studio, we have Caroline, who is the head of prevention and counseling. We ask her about the counseling bit, what they've been telling people with people who have contracted a disease. So she's the head of prevention, counseling, and nutrition as National AIDS and STI Control Program. And also we have Dr. Nanapoku, who is the Director of Technical Services, Ghana AIDS Commission. Both of them are in studio, so you'd want to share with us your messages, what you think of HIV/AIDS, what has been the question in your mind for a very long time. They are here to answer them. Endo, we have some messages.
Yes, there's some of the messages here. One says they're impressed with what we're doing. Is it possible to negotiate with the government so that HIV screening can be included to the normal routine labs for everybody, especially the youth who visit the hospital?
Maybe, Caroline, you want to pick that?
I think government is
Okay.
here.
Okay, so Dr. Puku.
Yeah.
No, HIV screening is free, but it is not mandatory. Even, let's be frank, even when you go to the hospital, right, and you are a pregnant woman, you have to be tested to look at your blood levels, HB. Essentially, it's not supposed to be mandatory. Okay? He asks you, please, we want to do this test on you. Do you agree? That is the normal. But because it had been routinely done and all over, it becomes something that is done. But every test conducted on any person, you need consent from that person. HIV test is free. Anytime you walk to any facility and you said you want HIV testing, it can be done for you. It can be done for you.
Wow.
Unless they don't have the test kits at that point in time. So, young man, we don't want to make it mandatory. Currently, it is not mandatory. There are about 3 or 4 circumstances that HIV testing is mandatory.
Pregnancy is part of it, I guess.
Not really, but it is.
So I don't know if I can just.
There have been a lot of contentions about pregnancy being mandatory for HIV testing, but actually, it's not. But you are offered, and you have to accept. Most people accept, and it's become routine as it is. Mandatory testing when you are donating your organ for transplant. It's one of the conditions that HIV testing is mandatory. Mandatory testing when you rape somebody, HIV testing, and you are caught, it can order you, whether you like, whether you refuse or not, it's mandatory. They will test you to find out your HIV status. Mandatory testing, I've talked about rape, blood transfusion aspect is also mandatory. And then by order of a court. Right? By order of a court. These are the few cases currently in Ghana that HIV testing is mandatory. There might be one or two.
Caroline, you want to touch on that quickly. After that,
pregnancy
you touch on how the counseling is going. Very important, because it also falls under
So I just to add on to Dr. Poku's submission, even though it's not mandatory, what we are doing at the facilities is that we are routinely offering the services. These days we are not sitting there for people to come and say, I want to have an HIV test done. As and when you are at the facility, we sell the service to you. That we have the services, they are free. And the policy is that everybody who comes, we should offer it to you as part of your routine services that we provide.
And which hospitals?
All the hospitals.
Public?
Public, private. And that is the same thing we are doing for the pregnant women. In fact, for the pregnant women, it's taken off fully. Ideally, OPD is supposed to be inpatient, every part of the facility, nutrition rehabs. So we have entry points for these places with test kits. And so as you do that, people now opt out. It's part of the services. If you, just as he said, if you don't want to be part, you can say, okay, I've heard, you've educated me on all that, told me all is free, but I don't want to do it now. Okay. And again, we have our HIV self-test kits available that we give out.
The self-testing, yes?
Yes. So at least everybody can, you give them out their instructions in it. We have videos and all that. The person goes to do it at the comfort of his or her home. So as you are watching us, look, go to, they are around.
We have some in NACP.
In Ghana is coming, yes. We have some in NACP. And so you can pick them and then test yourself. I think the challenge when it comes to this testing has to do with our policies too, and he is here. Now, anybody who is less than 16 years, before you do an HIV test, you need parental consent.
Oh, really?
Okay.
Yes. So if a 16-year-old come to me for services, less than 16 years, I can provide all the information, education, the counseling, but when it comes to taking the sample and testing, I will need that, a parent of that child or a guardian to give a consent.
What if I don't want mommy or daddy to see that
that is where the challenge is. Except if this less than 15 is pregnant or has children. We have that group we call matured minors. Aside that, the other 16 years, the policies So that is another area, gray area that we need to
policies and
there are some policies that are not helping us in a way.
For 16 years, the child may have done something
but
and run away from parents.
This thing is 18.
Okay.
Consent for sex is also is 18. So there are some policies that are not helping us that much. And as policymakers, we are looking at all that. And how to go around such. And even this, we talked about distribution of condoms in second cycle institutions. That's also a policy that is not helping. Though on the ground we know what is happening. You go to Cape Coast, and 13-year-olds are carrying twins in their bellies and all that. But we say we should not give them family planning.
Family planning.
What
culturally appropriate approaches could we use to increase education on HIV? And I don't know which of you would want to take that, because we're saying 13-year-olds are carrying babies. Meanwhile, GES says don't go and preach condom use or family planning methods in schools. So what culturally appropriate methods can be used in the interim while we wait for policies to be changed?
Look, you say you are government here, so over to you.
No, so the education, I mean, like the sexual education, appropriate for age and sex is what will help. Somebody was asking whether we still preach abstinence in our day and time where sex has become a game. for everybody, most people, not everybody per se. So it's difficult, but we need to inculcate that. Then we also have to ensure that we speak to the moral fiber of individuals. Though we are not pure, everything that will help us to make people understand and stop the transmission of HIV. So abstinence, teaching of abstinence, being faithful, sexuality education, prevention. You know, it's not only sex. HIV comes by drug use.
Drug use?
Yeah, drug injectors, those who inject drugs. In fact, is one of the easiest and fastest.
Also because I use it, I give it to somebody there,
Right. So those components, we have to ensure that we educate the youth on drug use. In fact, when you go to some part of the northern region, it's become so rampant. And all that. So HIV, that's why it's a multi-sectorial, multidisciplinary action. You'll be surprised that one of the prevention methods for HIV is keeping young ladies in school.
Really?
That's true. I believe it.
But the same schools, these children are doing whatever they want there?
No.
Oh?
Study shows in Eastern Africa that ladies, young, who complete secondary education, their risk of getting HIV decreases about 3 times. So keeping ladies in school is one key. We call that what we call structural prevention, one of the structural prevention, because there are certain systemic issues that pushes people into behaviors that let them get the HIV. And when we are able to solve some of these, even cash transfers, it has been noted that ladies and other youth in elsewhere, when they are giving cash transfers whilst they go to school, HIV incidence goes down. So employment is a way of even stopping HIV transmission.
Wow.
Keeping people in school is a way of stopping HIV transmission.
Wow.
So there are a lot of issues. Stigma reduction is a way of stopping HIV transmission.
Okay.
How can we encourage the men?
The men
and boys to get tested?
Yes. The self-test kit is one of the
the
ways we are exploring, and it's doing some good. It's doing some good. They don't go, you know, the self-seeking behaviors of men. It's a different story. They have to be bundled when they are almost dying in their bed before they accept to go to the facilities. So making it available in their own comfort of their own homes to test is a way. Also, in doing couple counseling, and our counselor is here.
Yeah, our counselor. Someone that sent a message, so I'll ask the counselor.
Okay, just
so before that, the counseling thing, how do you go about the counseling?
Yeah, I wanted to just
let me read these messages first.
I want to add on to the young ones. That as a program, we have funding under Global Fund, where we are working with a civil society organization, Hope for Future Generations, reaching out to adolescent girls and young women, and also adolescent boys and young men. And then we are working with Garnet, who is the sub-recipient for this HIV self-test distribution. And they are also reaching out to our headquarters, fisher folk, and all that as a way of preventing HIV and AIDS. Yeah.
So how do you go about the counseling? But before that, someone says that, hi, please, can I get the contact to the counselor? I need her help. I'm on ART, that's antiretroviral, right?
Therapy.
Another one too says that from your outfit, NACP should strongly target the slave queens and in the colleges and the universities to insist on men to use condoms. Most men are generally weak when it comes to using condoms. We men, when we get to that point, we can't think. This is coming from Justin. You say. This one said, good morning, I'm enjoying the conversation, but want to ask Doc for me.
Hold on, let Caroline answer a question, then you can ask Doc this question for him to answer.
Okay, that's fine.
Yeah.
That's fine. So Caroline, how you are going about the counseling bit and at your outfit?
Yeah, so at our outfit, what we do is we train the counselors in the country.
Okay.
Yeah, on how to counsel people. We have, before you test somebody for HIV, you must provide what we refer to as pre-test information. You need to give the person the basic facts about HIV. Okay, such that if the person even decides not to test and goes out, the person goes out empowered and equipped to educate others. And if the person tests positive or negative, we have services for those people. Now we are using a concept we call status neutral approach to HIV testing, such that regardless of your status, if you are positive, you are counseled, given post-test counseling, and it's a step-by-step form of counseling, which I cannot do here now, but the counselors have been trained, and when they do that, they give that information, then the person is put on treatment because the person is HIV positive. For the negative, there's another way of counseling the negative and linking to prevention. Okay. So STI management, screening and management, the PrEP is there. We talk about PEP, which is the post-exposure prophylaxis. That one, the first one we said before, that's spray. We have another one that when the exposure occurs, you can visit the health facility within 72 hours and get those medicines, which is post-exposure prophylaxis. So we talk about that and all the things that need to go on. And we also have another form of counseling, which is adherence counseling. Once you test positive, HIV care, for now, there's no cure. It is treatment, it's management.
Why don't we have a cure?
Well, a lot is going on. I think it is just the way the virus is, quite trickish, and a lot is going on.
Because we hear about HIV from like childhood, 1980 something.
Yeah.
Yes.
So the scientists are working hard, but for now there's no known cure.
There's a theory that they are making money, so they won't find a cure.
Well, those are
they're forcing. They're progressing. There's this gene editing technology that is being used, CRISPR. It's used for cancer and it's promising to help eliminate HIV. So let's keep our fingers crossed and then.
So just as we are saying, for now, as we said, there's no known cure. But HIV has become like one of the chronic infections that we have. The hypertension, the diabetes, and then it's managed. Okay. So the counseling focuses on all this, and then the adherence, because it's lifelong. Sometimes you ask yourself, if you are even given antimalarials, to take, how many of us or antibiotics for 7 days are able to finish? And the positive one will take it every day for the rest of his or her life. Wow. And so before the one starts, you need to counsel.
Every morning?
It depends on the time. Fortunately, we have evolved. At the beginning, people could take 6 tablets morning and evening. Now they've been able to put 3 medicines as a tablet taken daily. So the person decides when it is appropriate, because it's adherence. The person must take it exactly the same time.
So what if you miss it?
If you miss, we don't want missing. The counseling is that you can only miss 1 tablet. You can't, but if you must miss at all, not more than 1 of the tablets.
So what if you miss 2? That means
no, you can't.
It won't work again.
It will work, but we don't want that. The medicine is like that. The concentration in the blood is not supposed to go down because it's a virus. They can mutate. They can change the way they are, and so you take it. By the time the concentration will be going down, you need to top up, and it is only then that you'll stop the virus from multiplying. Okay, and there are a few that will go and hide in areas where the medicine concentration is not. Okay.
So
that's
Yeah, Doc. So there's a question here for you. Well, the person is asking about symptoms for HIV. Are there symptoms for HIV?
Hold on. He says, I'm enjoying the comment, but I want to ask Doctor for the symptoms of HIV that one can naturally observe without testing. Yeah. Is there such a thing?
It's difficult. No, it's difficult. Even HIV, when you have HIV and you have not gone to the A stage, you might not even see any signs or symptoms.
Wow.
At the onset of the virus getting into your blood, some people have some mild constitutional symptoms, a little bit of not feeling too well, maybe a little bit of fever. It's not high-grade fever that we know like malaria, but a little warmth, and might not even feel much things.
So ideally, anytime you are exposed to unprotected sex, after some time, go and check. Is that it?
No, we're saying that it tests about twice in a year.
Okay.
Twice in a year.
Okay.
Because we have that window period. If you immediately have sex, you think you are unsafe and you go and test, you might have gotten the virus, but the test will not detect it because of what we call window period, which lasts to up to about 3 months. So we're saying that normal human beings, everything fine, once, twice a year testing is quite a good thing.
You'll soon be taking your final comments, and as we are wrapping up the show, that is not the show entirely, but just on this conversation. Someone says that I'm a nurse in a health center, but we do not have HIV test kits. It's very difficult to get into maybe the rural areas to some other parts of the country. Caroline?
For now, we have test kits. We haven't run out of test kits. Sometimes they are just local shortages because from the national stores, it gets to the regional medical stores. People are supposed to request using a particular software, and then it gets there. And in fact, these days they don't even go for them. We have something we refer to as the last mile distribution, where these are carried with a vehicle delivering from facility to facility. So, Madam, kindly request through your girl miss, if you are a very remote facility, let your district do that on your behalf, and you'll have your test kits. Because for now, we really do not have any shortages
in the country.
Yes.
Anyway, so Doc, what is the biggest challenge for Ghana AIDS Commission in addressing the issue of HIV/AIDS in this country? You've spoken about funding. What other challenges do you have? Maybe you want to put it out for the various authorities to see how best it can be addressed.
Well,
then we come to
this is a
multi-dimensional,
multi-million question. You said apart from funding.
Yes.
Is the funding you put aside?
Most of the things are linked to funding.
Okay.
But we will want Ghanaians to support us and then to stop stigmatizing. For the commission, we have done a lot of work on ourselves. In fact, we are looking at our corporate strategy. So we try to remain very relevant by looking at our core mandate and then how we can reposition ourselves to order to end HIV and AIDS in the country. So this corporate strategy is ready, and we look forward to implementing all the goodies in there. And we know we are going to strengthen our base so that we'll be able to coordinate better the national response, we'll be able to do a lot of researches, able to generate credible and strong strategic information. We want to have a system where at a glance we are able to know what is happening everywhere in Ghana. Data systems well established and all that. And all this also is linked to finances. But apart from that, we're working very hard. We need to look at the research component. We are not doing so much in that field. Secondary data analysis and its use is something that we have to really strengthen. So people out there, support us in all the way you can, and then we have to intensify our prevention efforts at the decentralized level, at the regional levels. Most of the things sometimes happens in the HQ, and then when you go down, things are not really happening the way we want it to happen. So we want more support also at the regional levels and all that. We've launched last quarter Education Plus initiative. As I was saying, education is a means of halting HIV among the youth. And that initiative is something that was launched in 2021. And we, Ghana, is now the 17th country to join that global initiative that is high politically motivated to ensure that there's more commitment to ensure that young ladies, especially, complete secondary education. Apart from all the goodies it provides, finances, economic, and all that, it also prevents them from getting HIV. Thank you so much.
Thank you. Caroline, your final words?
Yeah, so it has to do with the set aside funding, but funding is key. Yeah, but what in looking, in moving forward, for us, we want to double prevention efforts. We want to ensure that we get these new technologies in country. And then we also want parents to support us. Parents, everything begins from the home. They should stop playing ostrich. They should educate their wards. Okay, it's not spoiling them, it's empowering them so that they know how to negotiate for safe sex if they must, so that they use their condoms. And then also are looking at leveraging on social media. One of our viewers talked about using slay queens. That is a proposal that we've written, looking for funding, so that we identify these people at the tertiary institutions who are following. And then we get peer educators, we train them to distribute our test kits, self-test kits. And then once they have following, once the right content is put on, we can use that platform to ensure that a lot of information on HIV prevention gets out there. We're also working at bringing on board the pharmacies, private pharmacies for PrEP and all that. Because once the lady goes to have an unprotected sex, the next morning she's going to the pharmacy to buy the morning after pill, the emergency contraception. Is it possible that that person can provide other services there instead of the family planning? We have already integrated that. We also look at the abortion care spaces. It means these people are having, so we have a lot, and then of course the general education that we will be doing. But I would say that all our viewers, the entry point to all this is for us to know our status. If you don't test, we will not know who is positive, and we will not know who is negative, who needs prevention services, who need treatment. So the first point is, please get tested for HIV. If you don't want to go to the facility, we can get you the self-test kit. You start from there. If there's a need, then we continue and then get you diagnosis. So that if you are negative, we can help you to stay negative and still live your life. If you are positive, we put you on treatment, you still live longer and have a productive life. And together, we will be helping Mother Ghana in this area.
Beautiful,
so thank
beautiful,
you very much.
beautiful.
Yeah.
Thank you so much, Caroline Adonadaga, who is the head of Prevention, Counseling and Nutrition, National AIDS and STI Control Program, and also Dr. Fred Nanapoku, Director of Technical Services at the Ghana AIDS Commission. Thank you so much. And we will try and bring you back here again. And we are hoping that you will see the adverts on HIV/AIDS run on TV so that the education can go downward. Because I think that if that is not in the system, a lot of people tend to forget that there is something called HIV/AIDS.
Yeah.
And you know, the gentleman.
I think you should play that song again. Doc missed it.
Yeah, so the producers, if we can end by playing the HIV/AIDS.
Play it every morning.
We should play it every morning.
We should play it every morning
and every evening.
We should play it every morning. Or Doc, you want to say something briefly?
No, I just want to say that I have some condoms in my car for
Oh,
yeah.
So they are
I like the resounding joy in the studio.
I can see what the cameramen are doing behind. We are excited. Doc has some condoms in his car for them. So thank you so much, Doc, and thank you so much, Caroline.
Caroline, we really appreciate your time.
We are grateful.
Thank you for having us here.
Thank you.
You can wait until marriage.
Tick tack, my bedroom. ChannelOne can't tell me so much about oh, my time. Yata, you go doctor, no ain't time. We rap him, me number myself. And yeah, but you are better now with them ain't time. Me no one come and say, oh, mess up him. No, me didn't hold them tick tack, I am bad. I'm out for much of you. You're in power, off a war. Nitty, Pino, Pom, chum, by anything. I'm a smart nip him. Me mademo magabu mawaga dalala ya halaga maba ace na manyawo akukuga anya Chicago yenya dam dago na majiba ya kodo ya la lamadeka Adonadaga yo ya naba condom la na sila do ya wune na ko inchi fafa na nafa du kona no jijim kaba cho kaba kaba
mata da ku muke zamu muku gargadi da wannan mugun ciwo HIV ke kashewa da baba da amma wallahi kun ji ko wannan ciwon HIV wallahi ba shi da kyau wannan gargadi friction ya rubuto ko kaki ko kaso wallahi mun fada.
It is real, my brethren.
You can maintain one lover.
Rastafari come to warn you.
If it's not on, it's not in.
But I'm killer, this is not so.
You can wait until marriage.
We got no remedy.
It's all about the AIDS. You don't want me to now. Don't forget about your condom. I know from the rubber socks. You know who you are. I'm not telling you.
My lad, yes, if you have better can recognize. Those years, you never come live in a paradise. 1 hour years make you feel free like ice. Natural robbers make you die like flowers. Mothers and women, them a die like houseflies. Don't you see, please take and recognize. And just think twice again. My lad.
Zinoba, show who can fall. Say he can't catch ya. Hold up on his mother. It's your baby. Sakapa, yeah. Narewabo. Enti down yanko. So down yanko. Munyan bonny down. Manyamini weni. Wapanyananu. Na Sunday baba.
Rastafari,
it's not on, it's not in.
it is a killer.
Until marriage.
Can't stop it. Oh, mama, hear my cry.
And you know, Yana, I'm the common at your drink. And then we could be on a question. You've been a year now when you're my home.
cancer. Yari kesi na ni dinka take international crew. Ya didn't call on my room. Unji dia dale mo www.com with me to the saman phone. We should swash a sock. Now we ask my attack crack me up on my come do.
Charlie, there is nothing wrong with having good sex, but use a condom, Charlie. There are many to select. Secure, Panthers, and even Durex. Use a condom, Charlie, and protect your health.
It's be real, but you sabi the deal. The last girl where you drop will be your last meal.
But tell them it's a dangerous disease. I'm on advising. It's on the surface is a warning. Put on your condom, protect this kingdom. Protection before the action. Abstention prevents abortion. Original score be warning.
Esta malani mio moja dele Koya dale krani fite boshi o enya ke agana mamufe
Wami anjani yo Eti Oruku maveshi Oruku minzifu Wami anjani yo Shawa mampino Yapa
I am scary, I don't